Hello friends, welcome back. Thank you for subscribing All or None Law. This is an effort to increase the knowledge in the field of the medicine. We are talking today about disorders of the low potassium, which is hypokalemia. Yesterday we discussed about the physiology of potassium balance. Hypokalemia is when your serum potassium is less than 3.5 milliequivalents per liter. You should always remember spurious hypokalemia when dealing clinically with a case of hypokalemia. Spurious hypokalemia is when actual serum potassium is normal, but when you measure the lab value, it's actually appearing as low. One of the reasons why that happens is when you keep the sample for a little longer period of time, or the temperature, ambient temperature is increased, it makes the cells to take up the potassium and hence it appears low. If you remember in my lecture earlier on physiology, I said that the potassium, most of it is taken up by the cells, and that is called as a redistribution of the potassium, and then it is slowly released into the blood depending on the levels to maintain the tight hemostasis. And then excretion wise, 90% is excreted by the kidneys and then 10% is excreted by the GI. So these are the three different ways why the serum potassium can go up or down. So let's talk about the redistribution and hypokalemias. Refeeding syndrome is because of the insulin that pushes the potassium into the cells, increasing the sympathetic activity as with any sort of body stress like MI, head trauma, beta-2 agonists, pseudoephedrine, ephedrine, theophylline, chloroquine, and tocolytics. Hypokalemic periodic paralysis, one should be aware of because you do sometimes come across these things clinically. It could be either genetic or acquired. Type 1, which is the most common type, is due to L-type calcium channel defect, and type 2 is because of the skeletal sodium channel defect. There is something called as the Thyrotoxic periodic paralysis, TPP. I have seen at least 2 cases in my career so far. Either it is Asian or Hispanic in origin. Thyroid hormone response to potassium channels. The attacks typically occur between 1 a.m. and 6 a.m. They are precipitated by rest or carbohydrate-rich meal. Hypokalemia's level can go as low as 1.1 to 3.7 with hypomagnesemia and hypophosphatemia. Sometimes you will be scared to see these patients coming as like quadriplegics, and you are like doing CT scan of the brain, CT scan of the spine to rule out any sort of spinal cord compression or to rule out a stroke. Hypokalemia due to induction of the Na plus K plus ATPase, which makes the cells to take up the potassium. A rebound hyperkalemia is common with repletion, so hence you got to be careful by constantly checking the serum potassiums when you're repleting these patients. And then propranolol can also be used sometimes to reverse the hypokalemia. So next one is the renal potassium loss. It could be because of the drugs like diuretics, penicillins, Fanconi syndrome. I included this here because there are certain medications which can cause these, like tetracyclines, where there is just defect in the proximal tubules and you're losing a lot of potassium. Amphotericin, phoscarnate, cisplatin, ifosfamide, and EGFR inhibitors, which are the newest medications. Aldosterone, as you know, acts on the ROMK channels and leads to secretion of the potassium from the tubules. Hence, hyperaldosteronism will lead to the same thing. Primary, when the aldosterone secretion by the adrenal cortex goes up. Secondary, when the aldosterone production goes up due to increased REN level, like renal artery stenosis, Page kidney, wherein there is a compression of the renal parenchyma because of the hematoma, leads to ischemia of the kidney, which in turn causes secretion of the aldosterone. Paraneoplastic process, and then renin secreting tumors. And the last we'll talk about the tubulopathies. So primary hyperaldosteronism is, we said, there is actually increased the secretion of the aldosterone by the adrenal cortex. It could be genetic or acquired. In genetics, it is because of the congenital adrenal hyperplasias, and there are so many different types. And then you have familial hyperaldosteronism, type 1, 2, and 3. Type 1 is one which you should definitely remember. It is called as GRA, glucocorticoid remediable aldosteronism. There is a chimerism of two enzymes, aldosterone synthase, which is in this step here, and 11 beta hydroxylase, And these two enzymes, when they combine, as you know, ACTH will act at this level and increase the secretion of the cortisol. It has very little effect on aldosterone normally, but because of the chimerism, aldosterone secretion goes up because of the ACTH and leads to hyperaldosteronism. Hence, when you are treating GRA, you give them not only spironolactone to block the action of the aldosterone, but also glucocorticoids to suppress the ACTH. Acquired could be hyperplasias in 60% of the times, adenomas less common, and carcinomas very rarely. When you have suspicion for hyperaldosteronism, you start checking serum aldosterone level and the plasma renin activity level, and you calculate the ratio, typically greater than 20:1, because in primary hyperaldosteronism the renin is suppressed. Aldosterone suppression test can also be done by like saline infusion. You can do that, but not a very standard at this point of time. We just use PAS/PRA, that is the serum aldosterone, plasma aldosterone level, and the plasma renin activity ratio as a screening test. And if we do see that it is coming positive, then we go ahead with CT scan of the abdomen to rule out any mass, and then depending on that we will further go with adrenal vein sampling to localize it. And this is just the flow chart how you proceed. So once you have biochemically confirmed primary hyperaldosteronism, you proceed with adrenal CT. If you have a mass less than 40, go for surgery. If it is over 40, then you do adrenal vein sampling. If results are normal, or there is only a micronodularity or bilateral masses, then you depending on your probability, if it's a high probability versus low probability, you further proceed. Syndrome of apparent mineralocorticoid excess, a very important syndrome. Normally cortisol acts at the level of the mineralocorticoid receptor as well as the distal nephron and makes you lose potassium and absorbs the sodium. But distal nephron has a way to control this action of the cortisol by converting it to cortisone through 11-beta dehydrogenase. When you use anything which will block this, you are increasing the level of the cortisol in the distal nephron and make distal nephron secrete a lot of potassium, and they become hypokalemic. They will not be Cushingoid because the plasma concentration of the cortisol will be normal. It's only in the distal nephron that this is happening, and hence leads to symptoms of mineralocorticoid excess. Example being licorice, and this is very commonly used in Europe in a lot of things, and this is something to keep in your mind. How do you diagnose it? You calculate the urinary free cortisol to free cortisone ratio in a 24-hour urine collection. A syndrome which is seen in pregnancy were called as MR, that is mineralocorticoid gain of function mutation, wherein even though without presence of the aldosterone, the mineralocorticoid receptors are just activating themselves, that leads to effects of the aldosterone with levels being normal. Progesterone is known to do this, meaning that progesterone will activate it, and hence you see symptoms common in pregnancy. Next, coming to the tubulopathies, Barter syndrome. If you want to remember Barter syndrome, think of loop diuretics. So what happens if you give loop diuretics, like you give every day bunch of loop diuretics to the patient and see what happens? So basically it's a loop diuretic, so you will keep losing a lot of fluid, so there will be growth and mental retardation. As you know, when you increase the urinary flow, you are opening up the potassium ROMK channels and the big K maxi channels and secrete more potassium, so they become hypokalemic. As you present more sodium to the distal nephron by blocking the channels in the loop of Henle, you make sodium exchanged with potassium and H+, so you're losing the protons as well, so they become metabolically alkalotic. And then because they are losing so much of urine, they will be polyuric, and they will be also thirsty constantly because of the volume depletion. They will also have decreased urinary concentrating ability because sodium chloride is required in the medullary interstitium to create a gradient for concentration of the urine. But because of sodium chloride being excreted, the urinary concentration ability is lost. There is also increased urinary calcium excretion, hence they will be hypocalcemic, and then magnesium concentration falls as well. They could be hypophosphatemic as well. Pathophysiology, remember, it's like loop diuretics, so they will block the sodium, chloride, potassium channels in the thick ascending limb of loop of Henle. What are the different types? There are 5 different types. Type 1 is the classic Na plus K plus Cl minus channel defect. Type 2 is the ROMK channel defect. Type 3 is chloride channel Kb channels, and this is the one which is seen in adults. So type 3 is the one which is seen in adults. Why not type 1, type 2, type 4? That's because they will die as a kids and they will not be able to make it to the adulthood. So type 3 is the one which is seen in the adults. Type 4 is the one which is associated with sensorineural deafness. Why? Because these chloride type A channels are also located in the semicircular canals, and then it's a combination defect of both type A and type B chloride channels, and hence it's associated with Barter syndrome with sensorineural deafness. Type 5 is the one which is associated with hypocalcemia, and this is the main feature, and it is a very mild Barter syndrome type pathophysiology will be seen, and it is due to defect in the calcium sensing receptor. So type 3 is seen in adults, type 4 is associated with sensorineural deafness, and type 5 is associated with hypocalcemia. What are some of the Barter syndrome like phenotypes? So one is the East syndrome, which is epilepsy, ataxia, and then sensorineural deafness and tubulopathies, and again it's due to chloride channel defects. And then aminoglycosides, as a matter of fact, can present like this, as like a Barter's type phenotype. Gitelman syndrome, think of thiazide diuretics. So Barter's is loop diuretics, Gitelman's think of thiazide diuretics. So thiazide diuretics, it will be less prominent compared to loop diuretics, correct, in terms of the diuresis. Hence these kids are able to survive their childhood and go into the adulthood. So in adult life, the most common type of tubulopathy you will see is Gitelman's compared to Barter's. Okay, so it is autosomal recessive. Again, you are losing potassium, you will be alkalotic, you will be hypomagnesiemic, hypocalciuric, and the blood pressure will be normal to sometimes low as well. But what's the main difference is hypomagnesemia and hypocalciuria are more prominent in Gitelman's. So these two, I want you to remember, these two are common with Gitelman's. What is Liddle syndrome? Now there is a channel in the distal nephron called as epithelial sodium channels. So epithelial sodium channels function is basically to absorb all the sodium. If you remember my physiology lecture, I said that when you absorb the sodium through the epithelial channels, you create a electrical potential gradient which opens the ROMK channels and leads to the secretion of the potassium. So these sodium channels are not dependent, just like your Na plus K plus channels on which thiazide diuretics acts, or Na plus K plus 2Cl minus channels on which loop diuretics acts. These are the different type of channels in the loop of Henle. So remember, ENaC should be on the tip of your tongue when I say Liddle syndrome. ENaC for Liddle syndrome. Thiazide type diuretic channels blocked in Gitelman's. Loop diuretics type channels blocked in Barter syndrome. Okay, so when you are absorbing all the sodium through the ENaC channels, so what are you going to create? You're going to absorb all the sodium. Along with that, you're going to absorb water. So you are creating a volume expanded state leading to hypertension. As you absorb all the sodium, you are creating more potential gradient, opening up a lot of the ROMK channels. You are secreting the potassium, so that you become hypokalemic. At the same time, you become alkalotic. And because of the volume expanded state, what are you doing? You are basically suppressing the aldosterone. It is seen at a very young age. It's a clinical diagnosis. How do you treat it? By giving amiloride or trimethoprim, which blocks these epithelial sodium channels. What are some of the other renal tubulopathies? Renal tubular acidosis, proximal and distal. Proximal is type 2, distal is type 1. Proximal is defect in the bicarbonate reabsorption. There is a mutation in the sodium bicarbonate basolateral channel, as is seen with Fanconi syndrome. Distal is there is decreased ability to acidify the urine. There is a reduced H plus ATPase activity and can be seen with Sjögren syndrome. It can also be seen with lupus. It can also be seen with lupus. Lupus can also give rise to type 4 RTA. Diabetes can give rise to type 4 RTA, which is the only type of RTA associated with hyperkalemia. Okay, what's the role of the magnesium in hypokalemia? You remember the ROMK channels which I was telling you. For ROMK channels, magnesium acts like a cofactor. So what it will do is it will keep the channels closed and prevents the potassium from being secreted. So if you lack magnesium, so these channels will continuously secrete the potassium out from the tubular lumen into the from the tubular cell into the tubular lumen, leading to hypokalemia. So when you are treating a case of hypokalemia, you should always make sure that the serum magnesium level is normal. Otherwise, the serum potassium level won't correct unless you correct the serum magnesium level. So this finishes the renal loss of the potassium. Now let's quickly give an overview on the non-renal loss of the potassium, which will be the GI tract. For example, nausea, vomiting, nasogastric suction, in like for example bowel obstructions, diarrhea of Leaves syndrome where there is a chronic pseudo obstruction. Now if you remember these BK channels, I told they are expressed in the distal nephron and are secreted whenever there is a high urinary flow state. These channels are also found in the colon, and their expression is actually increased in this syndrome, Gillies syndrome, and hence that is the reason why these patients get hypokalemic. It's also the case in patients with end-stage renal disease. Body will adjust by trying to increase these BK channels in the colon so as to make potassium secreted from the bowels. Okay, so this is the potassium loss from the bowels. So this brings us to the end of the discussion on the disorders of the low potassium. So disorders of the low potassium, remember, you have one is redistribution of the cells, second one is a kidney loss, and third one is a GI loss. Thank you. Please subscribe to our channel on YouTube, All or None Law.